So, good morning, all. Today I was given a topic which is pretty short, so difficult to have a long presentation. I'll still try to, present whatever best I could find in this particular statement because it is kind of a statement, not a presentation which can be made in a elaborate way. But still, I'll try to elaborate as much as possible with the relevant literature what is available. Maybe some deviation because anything cannot be absolute as per the statement. So this is what the flow of presentation would be. So the topic was relevance of small and large protosystemic shunt and outcomes with their obliteration. So let us first start with the evolution of spontaneous protosystemic shunts. And this is one of the paper which just came in 2024 Journal of Hepatology Reports, evolution of spontaneous protosystemic shunts over time and following etiological interventions in patients with cirrhosis. So what they found that if a patient has any kind of, he is having hepatitis C or alcohol dependence or hepatitis B. So if the patient is not cured, then the liver function will deteriorate and SPSS will increase. Whereas if a patient is cured, then liver functions improves and there is decreased SPSS progression. So we all know that. So there is nothing new about it. But what is important is that the presence of SPSS in cirrhosis increases over time and parallels liver function deterioration. So it happens, there is a balancing act. So bigger the shunt, poorer the liver function. So that's one thing. However, if there is etiological intervention, like you are treating hepatitis C, B, then these intervention in these patients reduces liver-related complications. But the SPSS persists, it is not going to go back, although the progression is slowed. So despite treatment, there is no confirmation that it will reduce in size. It will definitely eventually increase in size, but the progression will be slower if the patient is treated. And if untreated, definitely we know the liver function as well as the SPSS is going to increase. This is another interesting paper, 2018 Gastroenterology, and they studied the association between protosystemic shunts and increased complications and mortality in patients with cirrhosis. So if there is a SPSS, what they found that all patients, any grade, CTP, A, child A, child B, child C. So there will be more incidence of hepatic encephalopathy. However, even in cases of child C, you can see child C 42%, child B 64%. So definitely, whoever the liver function, more the complications. But that doesn't mean that if a patient has a very good liver function, then SPSS is not going to do any harm. So even in child A, the presence of SPSS leads to more complications and mortality. So SPSS in any patient is not good. That is what we understand with this paper. Now, this is another paper where they try to see the size and location of spontaneous protosystemic shunts and predict the risk of decompensation in cirrhotic patients. So time and again, it has been seen that the size, the location, the presence, and it is related to the decompensation. So SPSS is not good. That is what we are trying to, we are understanding with these literature available. And what they said, the cumulative incidence of not only hepatic encephalopathy, but also ascites. So this is interesting. So we know that presence of shunt will not lead to early ascites. Despite that, in a patient who has SPSS, will decompensate at some point of time and develop ascites, as well as varicose bleeding. So SPSS may be protective initially, but not for a longer duration and will have. And the risk of decompensation increased with increase in SPSS dimensions. So size of the SPSS increases, the decompensation will increase. And what is the size? If the SPSS is more than 8 mm, so they found that if it is more than 8 mm, the risk of decompensation is higher. And in their study, they found that gastrorenal shunt was an independent predictor of OLT and liver-related death. So liver transplant as well as liver-related death was higher in patients who had gastrorenal shunts, but it was this cohort It may be paramylical in other cohorts. So there may be any cohort. So I would rather put it the gastrorenal as well as the paramylical. They both are the, if their presence is seen within a large dimension that is more than 8 or maybe 10, whatever you consider, they are poor prognostic indicator. Then this is another paper where they talked about the total area of spontaneous photosystem. So rather than diameter, they said diameter is not actually the best way to calculate the flow. It should be area rather than the diameter. And they said that total cross-sectional FPSS area predicts the survival. So if you have to actually predict the survival, take the area rather than the diameter. And total cross-sectional area is an independent predictor of 1-year mortality and is associated with higher rates of hepatic encephalopathy compared to a small surface area. And again, what they found, the cutoff for the surface area that is associated with worse survival corresponds to a single shunt of more than 10 millimeter in diameter. So in previous study, it was 8 millimeter, it was 10. So we all now understand that anything more than 8 will definitely be significant and will lead to a poor prognosis. So 10 millimeter or 8 millimeter should be the threshold where we should start thinking, shall we treat it? But at what level should we treat? This is another question. When should we treat? Now, coming to the next part. So this is an interesting paper where they try to study changes in liver perfusion and function before and after percutaneous occlusion of spontaneous photosystemic shunt. So they found that liver function changes and total venous and hepatic arterial blood flow were evaluated using perfusion CT before and after shunt occlusion. So this is what they studied. And after shunt occlusion, total venous blood flow was significantly higher at 1 week, 1 month, 3 months as compared to baseline. So this is a simple that you have actually the hepatofugal flow has been stopped and it is made hepatopetal. So definitely the total perfusion is going to improve. But what will happen to the buffer response? They also studied. They studied that hepatic arterial liver blood flow became lowered. So this is actually balancing of the buffer response. So the arterialization of liver is actually reversed. And that is a good thing to happen. Arterialized liver actually deteriorates faster, whereas normal liver receives most of the total venous supply. So if you're trying to reverse it, probably it's going to help. And they also saw that serum albumin concentration became significantly higher than the baseline at 1 month and 3 months after shunt occlusion. Now, another paper, they studied changes in liver stiffness on real-time tissue elastography before and after occlusion of spontaneous photosystemic shunts. And they saw that the liver stiffness decreased. This is again in contrary to what we feel. So the liver stiffness decreased along with increase in liver volume, and it is very similar to our study. I'll talk about our study, our RCT also. So the liver stiffness decreases along with the increase in liver volume and improvement in liver functions after spontaneous photosystemic shunt occlusion. So the liver congestion may increase initially, but overall, in long term, the hemodynamics will change and the liver stiffness will finally decrease. But there is we need to understand that this doesn't happen in patients of all CTP score. This happens mostly in patients with preserved liver function. Wherever liver has a regenerative potential, there you will find these changes happening. But if liver is not actually good CTP-C with advanced fibrosis, probably this won't happen. But in early stages, definitely this happens. And it is not only our understanding, this is coming from Japan. Now coming to our study, we did a RCT in which we tried to study influence of shunt occlusion. So again, exactly coming to the same topic, influence of shunt occlusion on liver volume and functions in hyperammonemic cirrhosis patients having large photosystemic shunts. So what we saw that volume, we had two groups, standard medical therapy groups and shunt occlusion groups. And let us see the volume. So the volume pre-procedure in the standard medical therapy was 988. So this was the mean, but at 1 year, it became 904. So this is a very interesting finding. So if these shunts remain, then that will steal all the total flow, and this will lead to atrophy of the liver. So important is not that if you do make the hepatofugal flow hepatopetal, it is going to improve liver function. That everybody knows. What is important that if you are not treating, this liver is going to deteriorate. Why? Because there is atrophy. Why? Because the liver is devoid of any kind of vasoactive media which is produced in the gut for the liver. So gut is producing everything for the liver, though there may be some toxins as well, but the growth media is there to balance the homeostasis of the liver, which the liver is not getting because of these shunts. So these are decompressive shunts, but simultaneously they have their own problems, leading to gradual atrophy of liver, which is less reported. And in the shunt occlusion group, what we see, the pre-procedure liver volume was 1040 cc, which became 1132. So if you occlude, it becomes, so delta, if you see the delta on both the sides, it is huge. 1000 minus 100, 1000 plus 100. So actually the difference becomes 200. So shall we treat it? If you ask, yes, we should treat it, but we need to select the patient carefully where these occlusion is going to help them. And who are those patients? Those patients are patients who have early cirrhosis. So again, coming back to the same concept, we are talking about early intervention in most of the therapies. Similar to that, if we talk about shunts, we need to do it early before the liver disease advances, because once the liver disease is advanced, the regenerative potential, the reversibility, everything goes down, and probably it will lead to complication rather than any benefit. And we all know that albumin improves, ammonia decreases, DEXA improves. So all those things definitely keeps happening. And this is the bar diagram to show same liver volume. You can see it has increased. There was some improvement in albumin. This was significant. Ammonia decreased. DEXA was not very significant, but yes, there was some improvement. MELD sodium decreased, so patient improved. And this is how it was done. You can just see how the pre-procedure volume and the post-procedure volume looks like. Now, this is another recent article, spontaneous portosystemic shunt diameter predicts liver function after balloon occluded retrograde transvenous obliteration. So they studied 34 patients, the association of SPSS diameter and liver function at baseline and 6 months after BRTO and HVPG was investigated. Patients had child T scores of ABC, 7, 19, and 8. So most of the patients were child B, but there were some patients of A and C as well. The SPSS diameter was less than 10 in 11 to 20 and more than less than 10 mm, 11 to 20 mm and more than 20 mm. And less than 10 were 8 mm, 11 to 20 was 21 and more than 20 was 5 patient, and an average observation period was 0.3, that is 3 months to 8.5 years, and average was 3.2 years. The SPSS diameter was significantly correlated with the changes in HVPG observed upon BRTO, and a large shunt diameter was significantly associated with greater increase in HVPG. So it's very simple. Large shunt, shunting out large blood. As soon as you occlude, more blood will be forced to go towards the liver. And more blood is going towards liver, there is increased intrahepatic portal resistance. HVPG will definitely increase. And more increase in HVPG, that means more chances of decompensation in form of ascites and varices, formation of new varices. So large will have greater effect on HVPG. But simultaneously, they found that there was a significant improvement in albumin, prothrombin time, bilirubin, and ammonia. But the improvement was marked in those with larger shunt if they had childs A and B. This is what I have been telling. So those patients with advanced cirrhosis, they don't have such kind of beneficial effect. The beneficial effect is mostly seen in patients of child C, child B. This is our data. We published it way back in 2019, intractable hepatic encephalopathy in cirrhotic patients. So we studied 39 patients, and it was a long data follow-up was available up to 7 years. Complete obliteration was achieved in 37 of 39 patients. And what we made was we studied the logistic regression highlighted CTP score at 6 months as a positive predictive factor of HE recurrence with a cutoff of 9. What does that mean? That we studied who were those patients who developed HE at later period despite shunt occlusion. So there were some patients in which we did a shunt occlusion. Initially, they were absolutely fine. But after a year, they again started developing HE. But it was only a subgroup of patients. There were good amount of patients, good number of patients who didn't develop HE. So who were those patients? So we saw that those patients who had a CTP score of 9 or above, they were prone to develop new collaterals, enlargement of existing collaterals, whereas those who had a CTP score of less than 9, they didn't develop so much of collateral. So they did well. Again, the same thing in a different words. Early cirrhosis, they do well. And patients with preserved liver function show better outcome. And CTP score is the most important predictor of relapse during follow-up. So again, same thing coming time and again. 2026, this paper just came from Canadian Journal of Gastroenterology and Hepatology. Ultra-large spontaneous portosystemic shunt is correlated with a higher hepatic venous pressure gradient and increased risk of hepatic encephalopathy. So again, in this study, patients were categorized in 3 groups: no SPSS, that is none or less than 3 millimeter; small SPSS, that is 3 to 8 millimeter; and large SPSS, more than 8 millimeter. So the large SPSS group was further stratified in large, that is 8 to 14.5, and ultra large, that was more than 14.5. So there, it was their definition for large and ultra large. The large SPSS group had a higher total bilirubin and a higher incidence of HE than no SPSS. So this is no brainer. We know that large the shunt, larger the shunting, more the chances of HE. But the portal pressure lowering effect of SPSS does not correlate linearly with its diameter. What does that mean? That if a shunt is big, that doesn't mean that HVPG is going to decrease. If you see these patients linearly, even with increase of the shunt size, the HVPG is going to increase. That means the liver is going to deteriorate, the fibrosis is going to increase. So large SPSS is not directly correlating with the HVPG of those patients. Even larger shunts will have a higher HVPG because liver continues to deteriorate and the SPSS keeps enlarging. So this is what it means. Now coming to our data, which we have just analyzed, still we are working on it. So this was predictors determining poor outcome or complications after retrograde transvenous obliteration of portosystemic shunt in patients with cirrhosis. So we studied all patients from 2011 to 2025, and it was 297 excluded patients with incomplete data, and the patients eligible for analysis were 276 patients who underwent BRTO, because previously we were doing BRTO, was 75, whereas patients who underwent PARTO was 211, because at some point of time we moved ahead from BRTO to PARTO. So the cohort with PARTO had higher number of patients. And what we found that post-procedural hepatic decompensation occurred in 32.6 patients. So what was decompensation? Any patient developing any amount of ascites, that is we see very frequently, and that was seen in 32%. And encompassing 6.8% with overt hepatic failure. So there was a good number, 6.8%, 7% patient having overt hepatic failure, and persisted with newly developed 22.8% by 180 days. Why this happened? Because this happened because of the old data. If you go by the old data 15 years back, 20 years back, and at that point of time, still there was a cutoff for TIPS, but there was no cutoff for BRT. BRT was considered absolutely safe procedure. It can be done in CTPC. This is what has been written and documented in literature. And this is what we also believed initially, till the time we realized that no, there has to be a cutoff for patients who are undergoing shunt occlusion. It is a procedure which works well only in patients with preserved liver function. And that is what we are talking about, all the cutoff CTP A, B. But this is coming very recently in last couple of years. Still, there is no cutoff like in what we have it for TIPS. So that's why we see that these are the patients. So if we choose the patient properly, probably this will come down. The decompensation rate will come down and the hepatic failure rate, what we see, will come down. So these outcomes underscores the dual-edged nature of SPSS obliteration. So it is good, but it is not good. While redirecting portal flow enhances hepatic detoxification and functional reserve, it may precipitate portal pressure surges leading to decompensation events such as ascites, pleural fusion, and variceal aggravation. So you have to balance. You will have to see which one you want and where it will work. So the comparative analysis between decompensation and non-decompensated groups highlighted significant disparities in markers of advanced cirrhosis, including smaller liver size. You need to see the liver size. If it is already small, the chances of decompensation would be high. Larger portal vein diameter. So if it is portal vein diameter is good, yes, that's actually beneficial. Higher HVPG. Again, it's bad. If patient is already having high HVPG, you are further increasing the HVPG. Hyponatremia. That means the patient has a chances of decompensation. High CTP score and MELD score. We all know, we have been talking about it. Low platelet count. Again, it's not good. So higher platelet count, we are happy. Low albumin, not good. Higher sarcopenia. Again, sarcopenia coming here as well. So we see that sarcopenia is actually related to all aspects of cirrhosis. Where we see no sarcopenia, any therapy will work. More sarcopenia, none of the therapy is going to work. So what are the answers? Like we have been talking, so we know that certain patients will fit into obliteration, but there will be a good number of patients who won't fit into this obliteration because there will be patients with advanced cirrhosis where now we know that it may not be a good option because it will lead to decompensation. So what are the options? So there is something called proximal splenic vein embolization, or you can call it splenomesenteric dissociation. So if you disconnect this splenic circulation from the mesenteric circulation, so at least the flow from the splenic side will not contribute to the portal pressure. And I'll show you the concept. So this proximal splenic vein embolization concept is disconnecting mesenteric circulation from splenic outflow maintained by splenorenal shunt. So if you disconnect it, what will happen? Suppose you ligate the splenic vein. So splenic congestion will happen, but these patients already have a splenorenal shunt. So that shunt will act as an outflow for splenic vein. But at the same time, the mesenteric flow is not allowed to come out through that splenorenal shunt. It will be directed towards the liver. And this is how I have just made this, schematic diagram to make you understand what is happening. So this is the portal vein. If you see this, this is the portal vein. But what is happening because of increased intrahepatic portal resistance, all this blood flow is being diverted into splenic vein, splenic shunt, and into the renal vein. And simultaneously, the splenic flow is also getting into the shunt and the renal vein. So what do we do? Suppose we put a plug and we just block it. Once we block it, the mesenteric flow will be forced to go towards the liver. But the enlarged spleen with a massive flow, that will not contribute to the portal pressure, and that will be let out through this shunt. So you have made it's like division between two things. So you divide the pressure, the flow, and then you see that only small amount of flow which is coming from the mesenteric side will not contribute to sudden increase in portal pressure as what we see if we all occlude the shunt. So in BRT or PARTO, we occlude here. Rather than occluding here, we occlude here. So this, these both are disconnected. This goes this side, this goes this side. So splenic flow is not contributing to the portal pressure. This is how it is, and I'll show you an example. This was one of the patient. You can see a very small portal vein. As I showed you, a small portal vein is one of the predictor. Very small, a massive shunt. You can see such a big shunt. The bilirubin was high in this patient. Albumin was low, and INR was high. So all the factors. And if you see the liver, liver is small, atrophied. So we went from jugular side because the portal vein was very small. It was difficult to puncture percutaneously. So we went from the top. So it's almost doing a tips without dilatation. My sheath is inside. And what we have done, we have placed a plug. Initially, all the flow, you can see the contrast, everything going into the shunt, nothing coming towards the liver. But see, finally, when we take a run, all the mesenteric flow is coming towards the liver, whereas the splenic flow will come out through the shunt over here. So it's a good thing. And we have certain data to suggest that splenic vein helps. And this is one of the article, splenic vein embolization as a feasible treatment for patients with hepatic encephalopathy related to large spontaneous splenorenal shunts. And they studied 8 patients of persistent or recurrent hepatic encephalopathy who were successfully treated with splenic vein embolization. They saw that there was no immediate procedure-related complication. De novo occurrence or aggravation of symptoms related to portal hypertension were observed during long-term follow-up. That was no progression of esophageal varices. During the follow-up period, all patients were free of hepatic encephalopathy at 1 month of embolization. One patient had recurrence of HE within 6 months, and another one experienced a recurrence of HE within 1 year. So even in advanced cirrhosis, if you do such kind of a procedure, probably it is going to help. Another paper where they compared shunt embolization, that is DRTO, PARTO, along with this proximal splenic vein embolization. So in this group, 14 were treated with splenic vein embolization procedure and 13 were treated with shunt embolization, that was DRTO PARTO. The 6 months mortality after shunt embolization procedure was significantly higher than that after splenic vein embolization procedure. So there is a clear-cut demarcation in advanced cirrhosis. If you are going to do a shunt embolization, that means you are directing the splenic as well as mesenteric flow towards the liver. But if you do a proximal splenic vein embolization, that will lead only mesenteric flow to be diverted toward liver, which contains the toxic as well as the growth media, vasoactive media from the gut, whereas the splenic flow will be coming out through the shunt. So with this, I come to the end with the summary and conclusion slide. SPSS develops due to increase in intrahepatic portal resistance. Higher resistance is seen in advancing cirrhosis, leading to a larger shunt and is associated with increased chances of liver decompensation and deterioration. Closure of shunt leads to redirecting of portal flow and enhances hepatic detoxification and functional reserve. However, it may precipitate portal pressure surges and may lead to decompensation. And this is important. We all need to recognize this and accordingly choose the patient. Shunt obliteration has best outcomes in patients of CTP class A and B. And in cases of large SPSS with poor hepatic reserve, proximal splenic vein embolization may be a viable option. And we have done in about 5 patients this proximal splenic vein embolization in advanced cirrhosis, and we have found that this is a very promising technique, though we are not utilizing it as frequently as it should be, but it has a potential to treat those patients who have an advanced liver disease, but the suffering from HE and they are not eligible for BRT or PARTO. Thank you so much for your patient hearing. Questions.
total splenic vein flow will be blocked or partially it will be reduced?
No, total splenic venous flow is not going to block because there is a, that's why we call it proximal. So we put just beyond the confluence of mesenteric and splenic veins so that there is a shunt. Splenorenal shunt is patent. So the splenic outflow happens through the shunt. So it drains into the renal vein and then it goes into the IVC. Rather than splenic flow is not going towards the liver, but it is decompressing through the shunt into the renal vein. But spleen is not producing any kind of toxins. We are scared of, two things. One is toxins, which is produced in the gut. And ammonia is one of the things which we know. We don't know other toxins which actually causes a hepatic encephalopathy, but definitely there are toxins other than ammonia because those patients who have high ammonia, but still they may not have overt hepatic encephalopathy. So that's one thing. But splenic flow is not contributing to any kind of hepatic encephalopathy. So splenic flow is allowed to shunt through that shunt. So all the splenic outflow will come through the that splenorenal shunt, whereas the mesenteric flow will be forced to go towards the liver. So there will be some increase in portal pressure, but that increase in portal pressure won't be so high to overwhelm the liver for further decomposition.
So how it helps then for hepatic encephalopathy?
Because that is going to get filtered.
But
So metabolism will happen. It will go into the liver, and metabolism will happen. Whatever liver reserve is there, there will be some detoxification, isn't it? Only gut cleansing helps. Then why don't you think that getting into liver is going to help? And it actually works. It's not like it's my concept. It is proved, and studies are there, and we have also done studies.
Dr. Amar, excellent presentation. I had a question based on your experience, even amongst the child A and B. So we understand this is a pathophysiological basis of the liver, means the body's capacity to handle the portal blood flow and divert it with the shunts. So which shunts in the right phase? So patient has not reached the state of persistent HE or recurrent HE or gastric varices. So how do we identify which shunts should obviously be to improve the liver regeneration? How do we find that set of patients? Do we have any markers?
That's a very wonderful question. So really, I want somebody to take up that question. And I also want somebody to take up this as a thesis so that we can understand who are those patients. Because, it's difficult to make a patient as well as clinician understand that if a patient is not overtly symptomatic, shall we go ahead and treat? Because it is an invasive treatment, most of the people won't be convinced, as is in preemptive tips, as in is early tips for ascites. So anything where we want an early intervention, first we say, let us do a conservative thing. So till the time we come out of that mindset, it is difficult. But having said that, child say still you can skip initially for initial, but at least we can have B7. That is a good patient. We should at least do.
Our observation is, I don't know about your and others, because fatty liver or the metabolic dysfunction, we see many of these patients get these shunts on CT scans, and they do not have that much of portal pressures, but hypoalbuminemia is there as a marker, which we see in these patients. So that's my observation. I do not know whether.
So coming back to this paper, let us start with the first paper. So I think they have switched off it. Anyway, so this is a wonderful paper where they say that evolution of SPSS over time and following etiological intervention. So you can always obliterate the shunt and do an etiological intervention. If you are doing an etiological intervention, suppose it is a NASH, MASH, MSLD, there are so many terms, I'm confused. I don't know about those terms. You better understand. But those are treatable things as of today. We have drugs. But the shunt is not going to reduce. That's the observation of this study. The shunt will eventually increase over a period of time. PSA is a surface area. So do both things. Etiological intervention, but why not shunt embolization? Yeah, it should be done. I totally agree. But most of the people think because these are invasive interventions. Shall we do it? If you go to any of these ethical boards, there will be a question, why should we do? Is there any data? But if there is no data, who will create the data? Onus lies on us. But are we prepared? So question is not to me, question is to all sitting clinicians. Are you convinced? If you are convinced, yes, I'm ready to do.
So, so I have a question related to not to cirrhosis, but to non-cirrhotic total fibrosis. So, especially with the concept of total this proximal spleen vein embolization. So, one of the proposed hypothesis for NCPF is enlarged spleen, which itself leads to portal hypertension and subsequently leads to current gamma extinction. So whether this PSV can be helpful in these patients with NCPF where they have large shunt, where the splenic flow can be blocked, and then from the mesentery they can have a normal flow, and that can be current gamma extinction.
So can be tried, but again, there are certain things which are not reversible in NCPF. The kind of fibrosis happens at the portal venous end. Is it reversible? But yes, definitely it is will help in reducing the portal pressure and many of the symptoms. So it should work symptomatically, but in long term, how it is going to behave and it is going to reverse, is there any changes going to happen that we don't know? Because the splenic thing is one, but still I believe that gut is the major thing which is doing all the changes. And if you see the data today, each and every organ is talking about gut microbiota. Autoimmune disease at any level, any kind of such changes where we don't know what is happening, it is all gut microbiota. So here we cannot, cut the gut flow towards the liver. So gut flow is going to be there, but that should work. But are we doing any intervention on the gut side? That needs to be seen. There are so many things happening on the gut side. We still know nothing about it. But yes, probably, changing the gut environment, closing that splenic flow may help. But those are areas of research. I'm not the best person to answer as of now. But yes, and sometimes if we have more patients and let's study these patients, probably we will have more answers.
It's a very important area. And all of the time about and strongly shown much is spontaneous also produces a lot of kidney damage. And there is no nephrotic syndrome because of this shunt.
Yes, sir, that's a very important area. But again, is it gut or is it a spleen? That we need to understand. And I am in a favor that it is gut, it is not spleen. Because the spleen remains a spleen. Spleen has certain fixed homeostasis and functions. Whereas gut microbiota is constantly changing, we all know. That is the area where we are ingesting every time either we take good things, bad things, worse thing. And that is the microbiota is continuously changing. Everybody is studying. So it's the gut which is producing good or bad. So cutting a gut supply towards the renal vein may help. So that is what I was talking, that proximal splenic vein embolization, splenomesenteric dissociation may be answer to some of these patients with advanced liver disease, where we redirect only the mesenteric flow towards the liver, whereas the splenic flow can come through the shunt. That splenic flow may not contribute to the kidney deterioration. This is my understanding as of now. There is no evidence to suggest, there is no studies to suggest, but this is just my hypothesis as of now.
And how the
Thank you, sir.
Everybody should be geared up. It's in the morning. We will able to